Good evening, everyone. How are you all? Great. So tonight we are going to have our last session on the free 2 weeks class, right? So, and as you remember, we told in our last session with me that tonight class will be taken by Dr. Rabia. And she's one of the most favorite tutor in our course so far. And I'm hopeful that you guys will enjoy the class tremendously. Tonight's session is mainly on recent random question solvation. And it's just to show you that how we take our random question solvation class. This class you will get every week on the same day on Thursday. All right, so I hope that you enjoy this class. And if you have any question, feel free to ask Dr. Rabia. I will be here throughout the session, but she will take over the mic. So let us welcome Dr. Rabia, and then she can start. I will just stop my sharing for the moment.
Thank you so much, Dr. Arshan. Hello, everyone. How are you all? My name is Rabia, and I'm glad to have be a part of this course to help the students get their dream, that is to become and practice in Australia. So usually I only take the recall classes. Today I have made a presentation for you to let you know what type of questions come in the exam and how are you to approach these questions and what kind of sources you can utilize, which will help you a lot in your AMC MCQ exam and also your clinical exam as well. So let's start. Let me just share my screen with you guys. All right. Okay. So these are the sources that are mainly utilized in order to get a good grip and to make a good basis for passing this exam. Now, the book that you will be taking reference from, most importantly, is John Murtagh. It is like a Bible of Australian health system. It has all the knowledge you require from AMC MCQ. Almost all of the topics are covered in this book, and try to get the latest edition. Right now there is 7th edition, but 8th edition is also in the process or in the market right now. So try to get this edition because the guidelines or the protocols they utilize in Australia are constantly updated. So this book is updated every 6 to 7 months. So it has 8th edition going on. So try to get this edition. Besides the book, these are the websites that will help you in knowing what is the latest guideline regarding the management of a disease or a situation which we encounter in the health system. The RACGP, which is the Royal College of Australian General Practitioner, RCH, it is for the Royal Children's Hospital guidelines. It is recognized and practiced all over Australia. SA Health is basically for the gynecology and obstetric cases. And it is South Australian Health website. It has all the topics and all the guidelines in the form of algorithms and health charts that you require for your AMC, MCQ, and clinical exams. Health Direct is the website which is used by common person because it doesn't have any medical jargon. So it is very good if you want to read it and memorize it in an easy manner. Besides that, some of the topics which are not given in the John Murtagh, we can take help from Kaplan and also the MedBullets website, which is the step 1 and step 2 website. They have all the topics which are not given in the John Murtagh. Plus, the MedBullets also have a scenario-based question at the start of every topic. So it will help you to know what kind of disease is coming in the scenario, in what manner. All right. So let's start our questions. So these are the questions from recent exams of 2021. And if you get sample questions, most of the time they are based on the recaller's memory. So don't get upset if you think that the question is incomplete. Just try to get a grip of the basis they are asking in the question. All right. So a patient is on the list for surgery of the gallbladder. He is on a number of drugs. Which drug needs to be stopped 1 week before the surgery? Option A is ibuprofen. Option B, metformin. Option C, amlodipine. Option D, rosuvastatin. Option E, sodium valproate. Now here, they're asking your knowledge about the pre-op preparation of a patient who is on list for surgery. And this is the elective case. So they haven't given the name of the drugs that the person is on. They can give you that in the exam and you can choose from that as well. They have asked here which drugs you need to stop 1 week before the surgery so that the effect of that drug is washed out by the time the patient is having surgery. Option A is ibuprofen. Now, ibuprofen is an NSAID. Metformin is a bigonide. We give this to the patients who are type 2 diabetic. Amlodipine is antihypertensive. Rosuvastatin is a statin. We give this to control the level of the cholesterol in the blood of the patients. And sodium valproate is the anti-epileptic drug. Now, out of these, what do you think is the drug we should stop 1 week before the surgery? Stopping of the drugs before the surgery is done so that those drugs are not in the system of the patient and do not compromise the health of the patient during and after the surgery. So even if you think about this scenario, so metformin is very necessary to control the levels of glucose in the body, because if the patient is having high glucose during or before the time of the surgery, he or she will not be then liable to have the surgery. So we cannot stop this drug. We usually give this dose just before the surgery as well in order to control the levels of the sugar. So metformin is not the option here. Amlodipine is antihypertensive, and you also need to optimize the blood pressure of the patient who is going to have the surgery. So it is also out of the option. You usually give the dose just before the surgery as well. Statins, same principle as that. You have to control the level of the cholesterol, and it doesn't have any adverse effects in the post-operative outcome of the patient. Sodium valproate, very necessary not to skip it even during the surgery sometimes, because it is an anti-epileptic drug, and the patient who is on anti-epileptic drugs, they are having surgery. We don't stop this because there is a high chance of them getting an epileptic episode during or after the surgery. Now, ibuprofen is an NSAID. NSAIDs, they are anti-inflammatory. Plus, they increase the tendency of a patient to bleed out more during the surgery. NSAIDs, oral anticoagulants, We usually stop these 5 to 7 days before the surgery so that they are washed out of the system, optimize the patient's bleeding time, and then do the surgery. So our answer here is the ibuprofen. Any question, any query from this question, guys? All right. Now to explain this, I have utilized this guideline that I have found. Let's just go through this so that you are all cleared on what drugs to give and what drugs to stop before or after the surgery. Excuse me a minute, please. All right. Okay. Now this is for the patient, but if you go through this article, it tells us as a junior doctor, a lot of information for us to have as well. So whenever a patient is being admitted for an elective surgery, we always ask them to have a list of their medications they are on. All right. So what medications should I stop before the surgery? Now, anticoagulants. Blood thinners are required to be stopped several days before the surgery. Oral medication may be replaced with IV or injected ones. It is extremely important that both your surgeon or your physician discuss the optimum timing for stopping these medications, which is usually 7 to 5 days before the surgery. Okay, what are the anticoagulants? Warfarin, enoxaparin, which is the low molecular weight heparin, clopidogrel, ticlopidine, aspirin, NSAIDs in many versions. Any type of NSAID, stop before the surgery. Dipyridamole, non-prescribed or over-the-counter. Now, these are some of the anticoagulants which are always prescribed by the physician. They cannot be taken by the pharmacist over the counter. There are some of the over-the-counter anticoagulants that has to be asked from the patient that either are you on aspirin, NSAID of any kind, vitamin E, garlic, ginger, ginkgo biloba. These are the herbs. We have to ask these questions and need to stop these as well. All right. So what other medications beside these to stop 1 week before the surgery? Now, MAO inhibitors are also stopped 7 to 14 days before the surgery. This group includes the antidepressant and anti-Parkinson drugs. So patients who are having MAO inhibitors for their depression, or if they're having Parkinson and they are on these drugs, you need to stop these medication for 7 to 14 days as well. This is a list of these drugs. What medications can the patient take on the day of the surgery? This is also very important and one of the favorite questions of AMC in the surgery portion. Blood pressure medication or heart medication of any kind. Anti-seizure medication, acetaminophen containing pain medication, not the aspirin and NSAID, the acetaminophen ones. It should be taken on this day of the surgery with a slight bit sip of water. And you can also take diabetic pills. All right. So this was the answer to our question over here. So this is the way you find out the answer. If you can't find it on the Australian guideline, go for American one or the UK one. These are also followed by mostly practiced over here. But usually the Australian guidelines are available on every topic they ask in the AMC. So no need to look over here or there as well. All right. Our next question is, an old patient, always pay attention to what gender they're talking about in the question. what age group they are talking about in the question, and what risk factors they are talking about in the question. So look over here, old patient, 67 years of age, smoking history of 19 years. Now presented with confusion. This is the number one sign and symptom. And the number two is the chest pain for 6 months. So it's a chronic presentation. You have done the lab investigation and it shows the decreased amount of sodium. What is your diagnosis? Now, this is a 67-year-old male who has a smoking history of 19 years. So that is a very long history. Sometimes they give you the number of cigarettes that person smokes per day. That is also significant. Now he's having confusion and chest pain for 6 months. So this is not an acute event. This is a chronic event or chronic underlying condition that is going on. Lab investigations show decreased sodium. So we have to find out of these conditions, which one of these symptoms and the lab investigation and the risk factors match to. Our options are A, carcinoma of the lung, B, tuberculosis, C, brain tumor, D, myocardial infarction, and E, drug interaction. Now, as this is a 6 months event, so we know that acute events are out. So myocardial infarction and most of the drug interactions are also acute, meaning they are less than 6 months. They are not within the 6 months period time. So these options are out. Our remaining options are carcinoma of the lung, tuberculosis, and brain tumor. Brain tumor can present with confusion, but it has no correlation with the chest pain unless or until patient have metastasis inside the chest. But brain tumors usually do not metastasize to the lungs, they metastasize to the spinal cord and breast. So this is out. Tuberculosis, always remember, it's not a common disease in Australia. It is the disease of immigrants over here. So always in the question, they will mention something about immigrants or travel history. They will mention about something that the patient is in the detention center. They will mention something about prison. All right. And usually these patients will have cough with sputum and low-grade fever with night sweats. All right. So this is not happening in our patient. So tuberculosis is also out. Now the smoking history with the age is with the chest pain, is a clear indication of the carcinoma of the lung. But why the patient is having confusion and decreased sodium? This is very important to remember. Carcinoma of the lung has many types. Some of the types of the lung cancer also secrete some hormone-like substances. So we call that Paraneoplastic Syndrome. And it is in 10% of the population who are diagnosed with the lung cancer that these patients present with not the symptoms of the chest, but also the symptoms of the endocrine system. Like small cell carcinoma of the lung cause this syndrome of inappropriate ADH secretion, which can cause decreased sodium in the body, and the patient can have confusion along with the chest pain. All right. Any query, guys, on this question? So you need to correlate the age, the risk factors, the sign and symptoms, and the lab investigation. Once you have gotten a good basis of every topic, this will not be a big problem for you guys. All right. So these are the links. Let's look over here. All right. So paraneoplastic syndromes in the lung cancer occur in 10% of the patient. And the most common ones are, there are the two most common ones. Number one is the hypercalcemia in squamous cell carcinoma and syndrome of inappropriate ADS secretion in the small cell lung cancer. So every patient of lung cancer, besides doing the chest imaging, you have to do the lab as well to rule out the paraneoplastic syndrome. This is the RACGP guideline about the sign and symptoms, about the detection of the lung cancer. All right. Okay, now look over here. This is the guideline which is followed in Australia regarding the lung cancer. All right. So lung cancer is the leading. This is also one of the most commonly asked question in the exam, guys. What is the leading cause of cancer death or mortality in Australia? That is also the lung cancer. All right. So lung cancer is the leading cause of death in Australia. Symptoms of lung cancer can be non-specific and may hinder diagnosis and treatment. So risk factors are important in these patients. Lifestyle factors, environmental factors, passive or active smoking, occupational exposure, air pollution. Personal factor will always include increasing age. Sometimes there will be family history or some underlying chronic lung disorders or some other history of cancers. Symptoms, we know that they will have lung symptoms and they will have some paraneoplastic symptoms. So if patient is having sign and symptoms, these are the sign and symptoms in a patient which is more than 3 weeks. So always new or changed cough, chest or shoulder pain, shortness of breath, hoarseness of voice, weight loss and loss of appetite, very common for any cancer, persistent or recurrent chest infections because of the decreased immunity of the patient, fatigue, DVT. We all know that cancer is a hypercoagulable state, so DVT will always be there in any kind of cancer. Abnormal chest signs, finger clubbing is usually because of the chronic lung condition, so it's there. Cervical and supraclavicular lymphadenopathy because of the dissemination of the lung cancer or metastasis. A feature suggestive of the metastasis, pleural effusion, and thrombocytosis. Now, first thing you have to do is do the imaging of the patient. All right, we start with the chest X-ray. If there is some abnormality in the chest X-ray, we go for the higher resolution imaging for the staging of the cancer as well. So we do the CT scan of the chest. If the lung cancer is on the center part of the chest, we do the biopsy via bronchoscopy. If the lesion is on the periphery of the chest, then we can do it by thoracotomy. All right. So this is the way the RACGP algorithms are available. And if you just type the name of the topic and write RACGP in front of it, you will be able to get all the information required for the exam of that topic here as well. Now, I talked about Health Direct as well. So look over here. They have this kind of information. What is lung cancer? They have explained all of it about it here. What are the symptoms? What are the causes? When should I see my doctor? Now, this health site is usually for the patients, but it is very useful for us as well to identify the red flags in a patient, when to tell them to see the doctor as well. How it is diagnosed, how it is treated, how it can be prevented, what are the complications of it. All of the information is here. You guys can go through this as well here. All right. Okay. Apart from non-melanoma skin cancer, lung cancer is the most common cancer in Australia in terms of both incidence and death, accounting for at least 20% of the cancer death. All right, so very common. Paraneoplastic syndrome include hypercalcemia, Cushing syndrome, carcinoid syndrome. It is one of the tumors of the GI tract and it causes flushing, dermatomyositis, visual loss progressing to blindness from the retinal degeneration, cerebellar degeneration, and encephalitis. All right. The presentation of cough and chest pain renders this less of an occult malignancy than other several types. So the symptoms, the age, the risk factors, and the lab investigation all help you in diagnosis of a disease. And AMC exam is not an inconclusive exam. They give all of the information they think is enough to diagnose or to solve a question. All right, our next question is, an 8-week pregnant female, important information, 31 years of age, important information, comes to you and wants to assess if the baby may have Down syndrome. As she read on internet, the chances increase with the age. She requests for non-invasive testing method. What do you want to order for this patient? Option A, knuckle translucency at 10 to 13 weeks. Option B, maternal serum screening at first trimester and ultrasonography at 18 weeks. Option C, chorionic villus sampling or biopsy. Option D, amniocentesis. Now we know that Down syndrome, it is a genetic disorder. It is trisomy 21, which is a non-disjunction trisomy. And the chances of Down syndrome increase with age. So it is directly proportional to age. If the age increase, the chances of having a Down syndrome baby increase. And they have devised a whole screening method in the first trimester and in the second trimester as well. So in the first trimester, the patient has a specific request, which is a very important part of your exam here. If she is requesting a non-invasive testing, don't go for the invasive methods. So C and D are out. All right. Now we want the non-invasive one, which will be the ultrasonography. So here, maternal serum screening at first trimester and ultrasonography at 18 weeks, it is a wrong option because we don't do that in the first trimester. Ultrasonography is at the 18 weeks and they're asking about the first trimester one. All right. So knuckle translucency at 10 to 13 weeks. If it is increased beyond a certain measurement, then the chances of having a Down syndrome baby increase. And after that, or in combination with that, we do the maternal serum screening in the first trimester. Let us go through what kind of screening is done for the Down syndrome. All right. So look over here. Why test for Down syndrome? Because its incidence is very high in Australia. 1 in 1100 babies in Australia is born with Down syndrome. So its incidence is high. This is a genetic condition, we know that, and it will have some level of intellectual disability. They have distinctive features. They will have slanting forehead, epicanthic folds, and they will have distinctive features out there physiologically as well. Now, there are two types of prenatal tests we do in every patient we think can have the chances of Down syndrome. The screening test is done in every patient. Diagnostic test is done only on those patients in whom the screening tests are positive or are inconclusive. All right. So there are three types of screening tests we do for Down syndrome: the combined first trimester screening, the non-invasive prenatal testing, and the second trimester maternal serum screening. Combined first trimester screening, it is done between 9 weeks and 13 weeks. You have to remember the time period of it, all right? It is near the end of the first trimester. Just remember like this, all right? What do? You do a blood test. You look for the hormonal changes in the mother. You look for the level of the beta HCG. You look for the level of the inhibin in the mother. Alpha P, ATP, you look for the level of that hormone as well. Combined with this, you do an ultrasound in the 12 to 13 weeks to measure the thickness of the fluid behind the baby neck, which is called the knuckle translucency. So even if they have given a blood test, they have asked a non-invasive test, meaning that nothing is going inside. So opt for the ultrasound imaging because it is the non-invasive test. These results combined with the mother age show you the chances of having the Down syndrome baby. If there is a high chance, then we go for the non-invasive prenatal testing. It is usually done after 10 weeks, all right? And we look for the free DNA of the baby into the mother's bloodstream. Second trimester maternal serum screening, it is also for other genetic conditions as well, besides Down syndrome. So you look for the serum markers in the mother's blood in 14 to 18 weeks of pregnancy, and you combine it with the morphology scan at the 18 weeks. All right. The diagnostic test, if all of these tests give you some positive result, we go for the diagnostic test after explaining about the risk of miscarriage associated with these tests to the mother. We go for the chorionic villus sampling in the first trimester, which is between the 11 and 14 weeks of pregnancy. Risk of miscarriages less than 1 in 100. All right. And we go for amniocentesis in the second trimester between 15 to 18 weeks of pregnancy. And it's also having a risk of 1 in 100. All right. So this is the Down syndrome screening from the Health Direct. You can also check it over here from the RSCGP1. Same information, but in medical jargon. So first trimester screening, we have already discussed that it is done near the 9 to 13 weeks, and we do a ultrasound to check the knuckle translucency, and we also check for the blood serum markers. In the second trimester screening, the blood serum markers of the mother are also combined with the morphology scan near 15 to 18 weeks. All right, same thing is written over here. This is the risk calculation is not necessary for your exam. Just give it a read from here and you will understand the same information we have discussed before in the Health Direct. Okay, I have found this chart. So same thing, combined first trimester screening consists of an ultrasound plus a blood test. This is the non-invasive prenatal testing, which is the cell-free DNA screening. It is done from the 10 weeks. Second trimester serum screening is done between 14 to 20 weeks, consists of a serum markers in the maternal blood and also consists of a morphology scan. Management, the management of the Down syndrome baby. Are you asking that, Dr. Shaker? If the test, all of these tests, if they give a positive result, then the next step is counseling of the mother. You do the counseling, you tell about the situation, about the type of baby they are going to have. That is to be decided by the mother. That is only to be decided by the mother. You can give an option if you don't want to keep this pregnancy, you are having an option of going for an abortion. But you always counsel before. You never ever say abortion is the only solution you have here. You can't do anything because you're going to have a disabled child. No, it's not like that. You need to break the news to the patient in a very comfortable environment. The patient needs to have their partner with them so that they can provide emotional support. You can arrange a counselor for them after that as well, because it is a very this is very emotional news you are going to give to the parents. After that, you explain the situation. Yes, it's legal here, but it depends on the mother's choice. It is not to be decided by the doctor unless we tell the patient that she is having life-threatening conditions. All right. So here, Down syndrome baby are well managed because they have very good life expectancy. They are employed over here. They have relatively a normal childhood in Australia because they have all the facilities which can manage these patients. So usually you don't go for abortion in this management. You counsel the patient about the whole situation. You counsel about the diseases this patient the baby can have. You counsel them that there are facilities available to manage the baby condition. There are the pediatricians or the specialist available. And you counsel them that there are schools available like that and they have good employment rate. If she doesn't want any of that, then you can talk about abortion. All right. I have taken this part from your GM. In the chapter of the genetic condition. So we know that Down syndrome, trisomy 21, and they have typical features of flat faces, slanting eyes, prominent epicanthic fold, small ears, hypotonic, intellectual disability, and a single palmar crease. So this is typical for them. And the screening which we have talked about is also written in your GM. Excuse me. So we do the ultrasound, we do the maternal serum screening, and then we do the chorionic villus sampling or amniocentesis if everything is inconclusive or positive there. Same as that, what we have discussed before. This is from your GM. All right. All right. Okay, a man in 50s complains of numbness in the feet. He can't walk in darkness due to balance problem. So a man, 50s. He is strictly vegan, very important point, and looks pale on examination, also very important point. What investigation would you like to perform in this patient to reach the diagnosis? Option A, vitamin B12 level. Option B, CT scan of the head. Option C, MRI of the brain. Option D, nerve conduction studies. Option E, anticholinesterase antibodies. So a lot of you are opting for vitamin B12 level. What is the condition you're having in your mind right now? B12 deficiency, yes. Can anyone tell me about the condition this patient is having because of the vitamin B12 deficiency? Dr. Gloria, a wernic encephalopathy happens mostly in the alcoholics, not in the acute demyelinating syndrome. So yes, very good. We call the subacute combined degeneration of the cord. They have given you all some very important clues in this question. They have given you the change in the sensations of the patients, change in the or problems with the balance. And they have given you clues that he is strictly vegan and he is pale. Vegan, pale, having balance problem or sensory problem, always think about vitamin B12 deficiency or pernicious anemia. Pernicious anemia is an autoimmune disease, Dr. Anna. Um, it occurs because the antibodies are there against the intrinsic factor. So vitamin B12 doesn't combine with it and gets absorbed. And it's okay, Dr. Anna, we always learn. This is a learning platform. Ask questions, whether you're right and wrong. This is a learning process. And it's the best form of learning. When you make a mistake, you always remember that. I consider this the best form of learning. So in pernicious anemia, as you have raised a question, very good question. In pernicious anemia, there are autoantibodies against the intrinsic factor. Intrinsic factor is there to combine vitamin B12, and it helps in the absorption in the small intestine. So antibodies are formed against this. So vitamin B12 levels are normal, but it's not absorbed in the body, and patient is having signs and symptoms of the megaloblastic anemia. So if we find that patient is having the same sign and symptoms of the vitamin B12 deficiency, but on lab investigation, vitamin B12 levels are normal. So the next thing we do is we check about the autoantibodies against the intrinsic factor, and then we find the answer there. That something else is going on. The patient is not vegan, he didn't have any abdominal surgery, patient is not on any kind of medication that decrease the absorption of vitamin B12 level, patient is not having any parasitic infection. So what is the cause? That is the pernicious anemia, that is the autoimmune disorder. So you can go through that in the med bullets. It's very well written in the med bullets. Pernicious anemia, all kinds of anemias are very well written in the med bullets. So you can just write the name of the topic and write med bullets in your Google search box. Always give a scenario. So listen over here. A 55-year-old man is brought to his primary care physician by his wife for increased confusion. He forgets to turn off the stove after cooking and frequently misplaces his keys. He fell approximately 1 week ago while walking in the dark. His physical examination is notable for impaired short-term memory, decreased vibration and proprioception sensation, and patellar hyperreflexia. On lab testing, he has macrocytic anemia, reticulocytopenia, and low levels of vitamin B12. So this is how the scenario comes in the exam. They won't give you the lab investigation because it's obvious. They won't give you the low serum vitamin B12, but they can give you some sort of anemia, reticulocytopenia going on. So we know that it's a water soluble. It helps in the formation of the RBCs, and it can result in the megaloblastic anemia. It can have effect on our frontal cortex, causing reversible dementia. It can have effect on our peripheral nervous system, causing subacute combined degeneration. All right. So in which persons it's very common. So those who don't eat meat, so strict vegan diet, breastfeeding in a vitamin B12 deficiency mother because the baby sucks it out of the mother, decreased animal product intake, and some of the problems with the absorption like GI surgeries, chronic illness of the GI system like Crohn's disease, celiac disease, which is a malabsorptive syndrome, pancreatic insufficiency, some parasitic infection with Diphyllobothrium latum, or gastric atrophy. Some medications. Now, these medications are very important to remember, guys. Usually, when we are prescribing these medications long term, we are advised as doctors to advise our patients to increase their consumption of the vitamin B12 from the nature or take it in the form of supplements. So proton pump inhibitors, histamine receptor antagonist, and metformin. It also comes in the autoimmune disease, which is the pernicious anemia, autoantibodies against the intrinsic factor. No need to study the pathophysiology, symptoms, anemia. GI symptoms will be glossitis, and neurologic symptoms will be dementia, which is cognitive decline, and sensory loss in the subacute combined degeneration, weakness, spasticity, hyperreflexia, decreased vibration and proprioception, gait difficulties, ataxia. So we do the labs and we find out the macrocytic megaloblastic anemia, decreased level of vitamin B12, reticulocytopenia, and we can also look at the intrinsic factor antibodies as well. If we do the peripheral blood film, very important. If you look over here, this is the neutrophil, and this is the hypersegmented nucleus of the neutrophil. This is pathognomonic in the megaloblastic anemia of the vitamin B12 deficiency. Treatment is we either give, if the patient is having the neurological symptoms, always give the intramuscular vitamin B12. All right. You can study this from the Health Direct as well. Same thing they have discussed over there. All right. Okay. Our next question is post-colectomy operation. Patient is on post-op day 3 in the ward. You are informed by the nurse about the decreased amount of urine in the bag and a fever of 38.5 degrees centigrade. There was also generalized abdominal pain complaint as well. What is the next most appropriate management arranged by you for this patient? A, abdominal X-ray, B, urine analysis and culture, C, serum electrolytes and creatinine, D, ultrasound of the abdomen. Now here they are testing your knowledge about the postoperative fever causes. And what are the causes of the postoperative fever? Can someone tell me about the 5 W's? Yes, wound, wind, water, wonder drugs. Wound, wind, water, wonder drugs, and walk. All right. So there is a sequence of the post-operative day 1 fever, post-operative day 2 fever. The causes are different. The most common cause of the first day fever with shortness of breath, chest pain is atelectasis, or you can say wind, right? Second day is the same, atelectasis turning into pneumonia. Third day, if the patient is having decreased amount of urine or burning sensation, then it's the UTI. Fourth or fifth day, patient is having fever plus pain in the legs, then you think about DVT or cellulitis. Sixth or seventh day, patient is having high-grade fever and abdominal pain, think about abscess. So you need to remember the sequence of the post-operative day 1 fever causes, day 2 fever causes, day 3 fever causes, and the significant symptoms along with it. All right, so this patient is having post-op day 3 fever, but there is a decreased amount of urine in the bag. So patient is having catheter inside. Always think about UTI or urosepsis in this case. You want to do urine analysis and culture. If they haven't given you urine analysis and culture and patient is on first op day, then always think about atelectasis as the cause. Within the first 24 hours, mostly patient, because of the anesthesia, they are unable to expel the mucus, which is usually normally present in our respiratory tract. They are unable to expel it out, and it causes the blockage, leading to collapse of a part of a lung, leading to fever and shortness of breath. So we can do X-ray or ABGs to find out the status of the patient at that point. Yes, infection fever always occur after 24 hours. Very good, Dr. Sidra. Because patient's body is under stress because of the surgery. So infection takes time to develop. So it will be always after 24 hours, unless or until patient is having infection before the surgery. All right. Okay. So these are some of the pictures that help you to remember. First and second day, atelectasis or pneumonia. Talk about chest x-ray, talk about sputum culture if you are suspecting pneumonia. And you do the incentive spirometry for the atelectasis. You give antibiotics in case of pneumonia. Day 3 to day 5, you always suspect UTI. So you do the urine analysis, you do the nitrite, and you do the leukocyte count and give antibiotics. Day 5 to day 6, think about DVT, think about IV site infection. Day 7 is always the abscess one, incision site infection, cellulitis. So we do the physical examination of the surgical site, look for the signs of infection there, which is the redness, which is the pus, swelling, inflammation. And if it is abscess, we do the incision drainage because they don't respond to antibiotics. If there is cellulitis, then we give antibiotics. And day 8 to 15, you think about drug reaction and you think about deep abscess. If the fever is not subsiding on day 8 to 15 and patient is having high grade fever and you're not finding any cause, go for imaging. It might be the deep abscess in the pockets of the abdomen. All right. Okay. So same picture, same causes, the 5 W's and the time period, which is essential. Now I have taken this clip from your Kaplan surgery. So it has the postoperative complications fever. It has all the causes written over here and the investigations you do in a patient. So give a read from here as well. All right. Every potential source of post-op fever always has to be investigated. But the timing of the first febrile episode gives us a clue about the cause. So if it is within 24 hours, think about the cause to be atelectasis. If it is after one, then think about pneumonia. If it is on the 3rd day, think about UTI. If it is on the 5th day, think about DVT. If it is on 7 or more days, think about abscesses. All right. Just okay. Our next question is, sorry guys, just give me a minute, please. All right. So our next question is, a 27-year-old female who takes combined oral contraceptive pills. All right, important clues. She has come to you with painless vaginal spotting after intercourse and discharge for 3 days. Her last menstrual period, which lasts 4 days, was 10 days ago. Her last cervical smear test was 2 years ago and it was normal. Abdominal and vaginal examinations are normal apart from a mild ectropion with contact bleeding. What you want to do as an initial appropriate investigation in this patient? Option A, cervical screening test. Option B, colposcopy. Option C, endocervical swab. Option D, endometrial biopsy. Option E, pelvic ultrasound scan. Now she is a young patient, 27, and she is on OCPs. Periods are regular, so we don't need to worry about that. She came with the post-coital bleeding, right? And on examination, they have given you a mild ectropion with contact bleeding. Her cervical smear test was 2 years ago, and it was normal. All right. Now, what is the next investigation you would like to do in this patient? Most of you are saying colposcopy. So we know that this is not a problem of the uterus. So all of these options are out. We are stuck between option A and B. Now, we don't usually go to colposcopy direct. We never ever do that. We have to have evidence and justification for doing colposcopy. Just on looking through a speculum examination and finding a mass is not enough here. We need to do some investigation to find out what kind of mass it is or what kind of lesion this is. They have given you ectropion, or if they give you not ectropion or give you the lesion which bleeds on contact. So the first thing you like to do, you would do a cervical screening test in this patient. Yes, it is done 5 yearly, but the patient is now coming with you with a red flag. She's coming to you with a postcoital bleed. And on speculum examination, you have found a lesion over there. You don't just refer her to colposcopy. You have to do the cervical screening test again, and you refer her to the colposcopy. Then after the investigation shows something on this. All right. Is it clear, guys? This is a very confusing question, but it's one of the most important topics in the exam, the cervical screening test. So if a young patient who is on OCPs and is coming with you cervical with the postcoital bleed, most likely she's having cervical ectropion, and it does bleed on contact. But you don't leave this patient alone. You don't reassure this patient. You do the cervical screening swab. You send it for the cervical screening test, wait for the results, review the results. If there is something abnormal, then you refer the patient to the colposcopy. All right. If this patient was of postmenopausal age, then you would refer this patient to the colposcopy right away, because you know that this patient is in the context of having the cervical cancer. All right. But this patient is a young patient. She doesn't fall in the criteria of the cancer. So we need to have justification for that. If normal screening, then we reassure the patient, yes. If the cervical screening test is normal, Dr. Sidra, then we do reassure. We don't need to go for colposcopy. If the cervical screening test is inconclusive, we repeat it again. If the cervical screening test is normal, no need to do the colposcopy. It is just an ectropion. If the cervical screening test shows some high cell or low cell, then you investigate according to the screening protocol. Okay, let me help you guys with this. Let's look at this. So this is, they have talked about cervical ectropion here. We know that it is soft cells that line the inside of the cervix and that it comes outside. All right. And it's very common. And what are the risk factors for a patient having cervical ectropion? These are the 3 Ps. Either the patient is on the pill, which is the oral contraceptive pill. Patient is having puberty, starting puberty. Number 3 is patient is pregnant. So these are the risk factors of for developing the ectropion. So what are the symptoms? Patient will most likely present with light mucus discharge. That doesn't present like that. Spotting between periods, very common presentation. Pain and bleeding during or after intercourse is the most common presentation of the cervical ectropion. So we do the pelvic exam, we do the speculum examination. All right. And cervical ectropion is the most common cause of bleed in the last month of pregnancy because the cervix is dilating at that time. Effacement is going on. All right, so we know the causes. This is the 3 Ps. It is very rare in the postmenopausal female. That is why if they come with a postcoital bleed, we send them to colposcopy because we suspect some nasty growth lesion is going on. How it is diagnosed? It is discovered during a routine pelvic examination and pap test. The condition is actually visible during a pelvic exam because your cervix will appear red and rougher than normal, and it might bleed during the exam. Although there is no connection, but early cervical cancer do look like that. So we have to be on the safe side and do the pap test. If you're not having any symptoms and your pap tests are normal, you don't need further testing. If you're having any other symptoms and your pap test is abnormal, then next step would be colposcopy. And after that, the biopsy. Is that clear now, guys? You can also have the same here in the health navigator of the New Zealand Health. They have the same guidelines which is followed here in Australia, and they have talked about the same thing. So it's like this, it's red and rough. How it is diagnosed? Usually by examination, and then you do the cervical screening tests, which is the smear. You have to do it. You don't need to treat it. If it is so much bleeding, then you can do the cautery. Otherwise, you don't need to treat it. You just change the pill if the person is taking pill. If the person is pregnant, then you just reassure that after pregnancy, it will be normal. If the person is having puberty and not very severe symptoms, you can just reassure the patient. Now, this is for the postcoital bleed. All right, perform pap smear. Examine the cervix for evidence of the erosion or polyp. Perform pap smear if not done in the last 3 months. Do the chlamydia screening of the urine and cervical swab. If the STI screening positive, treat as such. If the pap test and other things are normal, then no need to do anything else. All right. If the abnormal pap test, then you have to do the colposcopy. You have to set no, if it is not done in the last 3 months. If it is done within the 2 months, then you can take that pap smear as your base. You don't need to do anything else. Can you look over here? They have mentioned in the last 3 months. So if it is done in the last 3 months, you don't need to do anything else. And if the patient is not having any severe symptoms, just reassure. All right. Our next question is, a 27-year-old pregnant lady who never had cervical screening test done now presents with postcoital bleeding in the 2nd trimester. On speculum examination, you have found a cervical ectropion and a laceration. What do you want to do in this patient? Now, similar topic, but different question. Now, our patient is now pregnant and never had cervical screening test done before. She is presenting within the 2nd trimester with the postcoital bleeding. On speculum examination, you have found a cervical ectropion and a laceration. What do you want to do in this patient? Option A, co-test or the cervical screening test. B, take sample of liquid-based cytology. C, to do the HPV DNA testing. D, do cervical screening postpartum. Or E, take a biopsy from the ulcer. So very good. All of you know that cervical screening test is quite safe in the pregnancy. So you have to do a cervical screening test in this patient. Very good, guys. All right. Our next question is, a 75-year-old lady with mild uterine prolapse and vaginal atrophy because she is postmenopausal. She drinks 7 cans of beer every night and 3 coffees a day. She complains of nocturia and wakes up wetting her bed. And she's here in the GP clinic asking you about the reason for her incontinence. Pay attention, they are asking about the reason. AMC loves to play with the words. So they are asking about the reason of the incontinence. Option A, stress incontinence. Option B, urge incontinence. Option C, alcohol intoxication. Option D, overactive bladder. Option E, uterine prolapse. So this is a postmenopausal lady with a mild uterine prolapse and vaginal atrophy. She drinks a lot of beer, 7 cans, and she drinks coffee, 3 cups of coffee every night. And now she is complaining of nocturia, wakes up wetting her bed. They are asking about the reason. Reason means they are asking about what is causing her nocturia. They are not asking you to diagnose the condition. They are asking the reason for the condition. She is having incontinence. And can anyone tell me what kind of incontinence she is having? So she is having urge incontinence. This is the condition she is having. Now, what is the reason for this condition? Is the overactive bladder, because she is drinking 7 cans of beer and 3 coffees, which cause and irritate the bladder. These are the stimulants. So she is having overactive bladder leading to the urge incontinence in her. Alcohol intoxication doesn't cause any incontinence. Uterine prolapse is mild. It's not disturbing her. It's not symptomatic. And it does. Uterine prolapse usually causes the stress incontinence, not the urge one, unless it is pushing on the bladder or irritating the bladder. So we know that if they ask you what is she having, what is the condition, you can answer it as urge incontinence. But if they are asking the reason or the pathology behind her condition, then go for the overactive bladder. See here how just a word changes the whole answer. And that is what AMC loves to do. They change a single word and their whole answer changes. So RSCGP has all of the guidelines you need to study about the overactive bladder syndrome or urge incontinence, the treatment option, and what we do over here. Give it a read. Detrusor overactivity is the most common cause of the nocturia in the urge incontinence. Causes we know, diagnosis is usually clinical, but we always do the UTI screening. We do the urine analysis to exclude the infection, hematuria, glycosuria to rule out the diabetes. We do the ultrasound as well to find out if there is any kind of obstruction there, and we do measure the post-residual volume, which help us to diagnose this condition. All right, and we do, if we don't have an inconclusive test, then we go for the urine cytology and dynamic testing, or we can also go for the cytoscopy and imaging of the upper urinary tract, but these are done by the nephrologist. This is not done by the junior doctors. We are supposed to do these. All right. So what can we do to help this patient? First of all, we need to ask her to have some lifestyle modification. Drink less beer, do not drink coffee when you are going to bed. And we ask them to do some bladder training exercises along with the pelvic floor exercises. If it doesn't help, we also ask them to do some weight reduction as well. If it doesn't help, then we go for the drugs. We go for the antimuscarinic agents, which are the oxybutynine, tolteridone, solifenacin, and darifenacin. If the patient is, vaginal estrogen is usually given in the postmenopausal females who are having some vaginal atrophy. All right, if these drugs are not affecting our patient, then we go for some interventional therapies. We can do the sacral nerve stimulation. And lastly, we can do some surgery to help our patient. So it has all the information you need in here. Some also do the intravesical botulinum toxin within the bladder, but it's for just 6 months. You have to repeat it again and again. And third line therapy is the nerve stimulation done and the cystoplasty surgery, which can be done. This is also one of the RSCGP guidelines regarding the urinary incontinence. So give it a read, guys. Okay, these are the part of your JM. I have taken female urinary incontinence and what are the types. So simple stress incontinence because of the increase in the intra-abdominal pressure, you have it, and the likely cause is because the sphincter of the bladder is incompetent. Urge incontinence because of the overactivity of the bladder. It can also be mixed as well. Dribble incontinence is because of the incontinence of the sphincter and bladder. And in males, it can be because of the prostate enlargement. Female urinary incontinence, most commonly in young females, is because of the stress incontinence, because of multiparity, the sphincter muscles are relaxed and doesn't support your pelvis that much. And that is why they are having stress incontinence in females. And in the older age, they can have urge incontinence. There are some drugs as well which cause incontinence. So we always do the diapers causes of the incontinence in the history. We ask the patient, we check the patient about delirium dementia, infection of the UTI tract, atrophic urethritis. We ask about the diuretic drugs they're taking. Are they under any kind of psychological stress? They are having any endocrine conditions like diabetes or hypercalcemia, or in the environment, we ask them about the kind of stuff they are putting inside their bodies, or the environment like unfamiliar surroundings can also cause it. Restricted mobility, stool impaction is also one of the cause because it puts pressure on the bladder, and sphincter damage is also there. So management is that we always exclude the UTI and drug causes. If it is stress incontinence, the patient will lose control of the bladder on coughing, jumping, and we ask the patient to do some pelvic floor exercise, decrease their weight. If patient is menopausal, we give them the hormone creams to help with that. And if the chronic cough is there, we do the physiotherapy. And if it doesn't help, we go for surgery, which is the suspension or tape surgeries. If it is urge, we do the bladder training. We remove the agents which are causing it. Then we go for the drugs. And if it doesn't help, we go for the botulinum injection. If it doesn't help, go for the sacral nerve stimulation therapy. If it doesn't help, then we go for the surgery. All right, so this is all of the things which is written in your JM. Okay, our next question is, a female had malware rash on her face. Lab results show that she's ANA positive and anti-Ro and anti-La positive. Now she came with a complaint of chest pain, number one. Number two, she's having fever as well and breathing difficulty when she is changing positions. What to give her for management? Option A, infliximab. Option B, prednisolone. Option C, hydroxychloroquine. And option D, methotrexate. Now, can anyone tell me what this patient is having as a first diagnosis and what is she now presenting with? So the first diagnosis, she's having malware rash on the face, and the lab result of ANA positive is SLE. Very good, Dr. Yash. Very good, Dr. Dr. Sidra. Very good. Dr. Shiraz. Dr. Liba. Very good. So she's having SLE. But now she's having chest pain, fever, and pain in breathing when she changed position. This tripod is typical for which disease, which is the complication of the SLE? Right? In pericarditis, there is the inflammation of the pericardium, which is the layer surrounding the heart. And when a patient is having pericarditis, they will have fever, they will have chest pain, and they will have breathing difficulty when they change position, or they will have chest pain when they change position because the inflamed pericardium is touching the chest wall. So we know that in SLE, the main treatment is to give the immunosuppressive agents or the anti-malaria if the patient is having rash or joint disease. But if the patient is having flare-up or complication of the SLE, especially pericarditis, then you prescribe the patient with methylprednisolone. Clear, guys? Now let me walk you through it. Mild pericarditis in an SLE is a flare, meaning the condition has flared up. It can be treated with the intramuscular steroid, which is triamcinolone injection, or you can give the oral methylprednisolone. Severe pericarditis, which can lead to the development of the pericardial tamponade, should be treated with the IV steroids. It is one of the most common heart problems associated with the active lupus, and it occurs in 25% of the people. All right. It is a condition when the pericardium becomes swollen and irritated and cause leakage of the fluid around heart. One of the side effects of the pericarditis is pericardial tamponade. So this is also from your JM. SLE, connective tissue disorder, most common in the females, autoimmune one, arthritis, most common feature, fever, malaise. We have the diagnostic criteria of the malar rash, discoid rash, photosensitivity, arthritis, oral ulcer, serositis, in which there is pleurisy or pericarditis. Then there are kidney features, neurological features. There are some hematological features. Immunological features means there is positive anti-DNA, anti-phospholipid antibodies, which is the anti-Rho, anti-La one, anti-Smith, and false positive syphilis serology. ANA is a diagnostic criteria. All right. So management, we know that if it is a mild one, we start with the NSAIDs, especially if it's arthralgia. If the patient is having skin rash along with the arthritis, then we give low dose antimalarial, which is hydroxychloroquine. But if the patient is having some flare up, or if the patient is having complications, especially multi-organ ones like serositis, we prescribe prednisolone. If it is not working, then you can move towards the immunosuppressive drugs like azathioprine, methotrexate. Always give folic acid with methotrexate because it causes deficiency. DMARDs like rituximab and belimumab. Now, as the patient of SLE is having remittance and flare-ups, so you don't usually give drugs to the patient who is in clinical remission and who is having normal complements level. It's one of very important part to remember in the treatment of the SLE. All right. And we also ask these patients because they have malar rash, discoid rash, and photosensitivity. So we ask them to avoid sunlight and use large amount of sunscreen. All right. And with SLE, antiphospholipid antibody syndrome is associated, which cause miscarriages and thrombotic episodes. This is a very important topic for your obstetric portion of the exam. Clear, guys? All right. 72-year-old female, she was walking. Suddenly, she tripped and fell down. She heard a crack sound and her ankle movements were painful and restricted. Calf pain is there, swelling in the distal end of the calf. Now, what do you want to do as the next best investigation in this patient? Option A, duplex ultrasound. Option B, X-ray. Option C, bone densitometry. Or option D, vitamin D and calcium level. let me help you out a bit over here. She is 72, meaning she is postmenopausal, and she had a very low trauma that resulted in a fracture. Now, what do you want to do as an initial investigation in this patient? All right, guys. Any patient who has some trauma and heard a crack sound and there is swelling around that part and restriction of movement, forget she is 72-year-old. Any patient who had trauma and on a limb and they heard a crack sound and now that part is painful, swollen, and it's very difficult to move. What do you want to do as a first investigation? So we'd always do the X-ray to rule out the fractures, right? She is having low trauma fracture, but she is having fracture altogether. Postmenopausal female having low trauma fracture, we know the underlying cause is osteoporosis, right? But she's having fracture. So the immediate management should be focused around to stabilize her fracture. For that, we do the X-ray. Now, once we have stabilized her condition, the next thing we will do is the vitamin D and calcium level and bone densitometry to find out what kind of bone density she is having. All right, so this is the osteoporosis topic guideline by RACGP. All right. So diagnosis, minimal trauma fracture of hip or a spine in a person older than 50 years of age. We always assume that it's because of the osteoporosis. And if there is a fracture of the hip and spine in a patient of more than 50 years, you don't need to do BMD. You don't need to do the bone mineral density. You just start the treatment after checking the vitamin D and calcium level. All right. So we always do the false prevention in this patient. We always check the level of vitamin D and calcium before starting the treatment, which is the bisphosphonates, because we want to have the normal level so that we can prevent further polarization of the bone. All right. That is why we optimize the calcium and vitamin D level before starting the bisphosphonates. Exercise is very important recommendation for them. And usually we give them bisphosphonates for 5 years and repeat the testing. If the patient is still having fractures, then you do the repeat testing to find out if she's having more osteoporosis or not. So give it a read over here. This is the recommendation for the minimal trauma fractures in patient. All right, if it is a fracture of any other side other than hip and vertebra, we do the X-ray of the spine and proximal femur, or plus the X-ray of the part that is fractured. All right. Okay, our next question is, patient is having ear discharge for 6 months, now presents with pain. On examination, you found a polyp in the ear with a dull tympanic membrane and a whitish mass. What will be the initial investigation in this patient? Option A, swab. Option B, biopsy of the polyp. Option C, CT scan of the tympanic membrane. Or option D, blood culture. Now, can anyone tell me what is the diagnosis in this patient? He's having ear discharge and pain. Now he's having a whitish mass in the ear with dull tympanic membrane. What is the diagnosis here? guys? All right. So any patient with a discharge from the ear and a pain for 6 months falls in the category of the chronic otitis media. Now, along with chronic otitis media is having complication as well in the form of the whitish mass. So patient is having chronic otitis media with formation of the cholesteatoma. Cholesteatoma is like a debris which collects over time, and there's a keratinization of it in the ear, leading to formation of a whitish mass, and it causes pain and hearing loss in the patient. So always in a patient coming with discharge from the ear, you always start with the swab. Then you do the CT scan of the tympanic membrane. You don't do the CT scan of head and neck to check whether the extension of the whitish mass is where. And if there is a polyp and you find out it to be a nasty growth, then you do the biopsy. There is a stepwise approach to this patient. You first do the swab, then you do the imaging, and then you do the biopsy. Because this patient is not having just a single disease, he's having complications and a superadded disease as well. So stepwise approach is necessary over here. All right. Okay. Any question from this, guys? So you can look over here about what to do in the chronic middle ear infection. It's the same that I have talked about. Chronic middle ear infection are the ones which are not resolved. The acute infections which do not get resolved, they cause the chronic infection. And usually patient can have ear loss and ear discharge. All right, causes, we know that it can be caused by the acute middle ear infection. Sorry. And if you can see, it can also be caused by the middle ear or the nasal passage because of the eustachian tube. Complications, it leads to formation of polyps in the middle ear. It leads to the destruction of the bones in the middle ear, and it leads to formation of the whitish mass, which is cholesteatoma. So patient will have discharge, hearing loss, pain, all of them all together. Can you appreciate this whitish mass over here? This is the cholesteatoma over here. And this membrane, tympanic membrane, is a very dull one. Let me show you the tympanic, normal tympanic membrane, so you guys can appreciate it well. Okay. If you look over here, guys, are you guys able to appreciate my screen? All right. If you look over here, can anyone let me know in the chat box? Are you able to look at the screen? Okay, thank you. So if you look over here, when we put an otoscope inside the ear canal, the light from the otoscope is reflected over here and it's bright and shiny. All right. This is a normal tympanic membrane. Now let's look at the acute otitis media one. It will be very red because there is infection going on. So it will be red. And if it is a pussy one, you can appreciate the level of the pus in like this. And if the canal is perforated, then you can appreciate this tympanic membrane is perforated and this pus is now coming out. Look at this picture as well. This is the bulging and very painful acute otitis media. And pain is because the pus is putting pressure on the tympanic membrane. Once it ruptures, the pain is gone. So this is the chronic one. And because of the repeated infection, there is cholesteatoma formation over here, which is this whitish mass. So we know that we do the examination by an otoscope. We take swabs for cultures and we do the imaging if we see there is a polyp there or some extension of the cholesteatoma in the middle ear. All right. And treatment, always do the toileting of the ear. And we can also give a wick inside the ear. And if it is a cholesteatoma, we remove it surgically. Doctors clean the debris from the ear first. The debris, the wick we use, it is dipped in with the antibiotic. All right. Okay. So this is from your GM, guys. So if you look over here, it's a perforated chronic otitis media over here. There are two types of chronic otitis media, one with the suppurative one and other one is the safe one. The safe one is the one in which there is no formation of the cholesteatoma. And the unsafe is the one where the cholesteatoma has formed. So discharging one is safe. All right. If there's only discharge and it is more than 6 weeks, it's safe. You can just give antibiotics. But if it is the development of cholesteatoma, then it is the unsafe one. All right. So cholesteatoma development means that there is chances of person having a permanent damage to the tympanic membrane. So this is all from your GM. All right. Now, management of the chronic otitis media is always that you clean the ear with the help of a toileting. Then you prescribe the antibiotics to the patient. And if it is cholesteatoma present over there, you can remove it or refer the patient for it to be removed by an ENT specialist surgically. All right. Okay. Our next question is, a 5-year-old boy is not keen to go to school. Reason is that he's with father all the time after they were attacked by people who broke into the house. Now, this is a traumatic situation the boy has passed, and he doesn't want to go to school. What treatment would you recommend for this 5-year-old boy? A, escitalopram, B, fluoxetine, C, psychotherapy, or D, you admit this patient into the hospital. Very good. Now we know that we never start the drugs in any psychiatric patient unless or until this patient is having some psychotic episode or patient is suicidal. We never, in psychiatry, we never go for drugs as a first line. All right. We always go with the psychotherapy first. Just remember, guys, if it's a mild psychiatric disease, never go for the drugs. Always start with the psychotherapy. Either it's cognitive behavioral therapy, exposure response therapy, it is crisis therapy, or traumatic therapy, which is for the PTSD patients. Now, this patient had a traumatic experience. He or she may be, because of the time period, may be experiencing the acute stress syndrome or maybe experiencing the post-traumatic stress syndrome. And the treatment of both these syndromes is same, that you give psychotherapy first, and then you give the patient SSRIs if their symptoms are not controlled. You don't do it like that, that you give psychotherapy first and then you give medication and stop the psychotherapy. If you are doing psychotherapy and you think that it's not helping, you add the medicine side by side to the psychotherapy. You don't stop the psychotherapy and go to the medications. It's not like that in the psychiatry. So PTSD in children, we know this is cognitive behavioral therapy. Medications are for depression or anxiety, and it is done after cognitive behavioral therapy is not working. You can study the stress disorders in the children from these sites. So look over here, cute little baba. So post-traumatic stress disorders in the babies, and it's a bit different than adults because these children, they're not able to express their symptoms in words. They will exhibit physical signs to you. So what are the signs? They will have behavioral problems. What kind of symptoms? Hypervigilant. They will be always looking over their shoulder. They will be very hypervigilant of their surroundings. Any loud noise will make them jump. They will have separation anxiety. They will be more clingy, or you cannot say clingy. You can say they will have anxiety on being separated from their guardians or parents. When they are reminded of initial trauma, they get visibly distressed. They start crying, or they will exhibit some kind of physical symptom when they are reminded of the initial trauma. Fear and avoidance of places. Now, this is an unconscious effort on their part. They are not doing it consciously, but unconsciously, their mind will divert them away from the event that will remind them of the trauma. They will have trouble sleeping, they will have nightmares, they will have repetitive play in order to seek some kind of normalcy. So we always start with the behavioral therapy, and then we go for the um, we go for the medications. Never ever start with the medications in the patient who are psychiatric and they're having mild illness. Psychotic patients, patient having a major depressive suicidal episodes or suicidal thoughts, always do medication as a first line in those after involuntary admitting them in the hospital. All right. Our next question is, a 19-year-old, 45 kg weight. She has been abusing laxative. She vomits after she eats. She also has ankle edema. 6 months ago, her father died, after which she lost weight significantly. And she sees the ghost of the father everywhere, telling her that she is responsible for his death and she should be thinner. What is the cause of her condition? Anorexia nervosa, complicated grief, and depression. Very good. Now we know that she is suffering the the condition she is having. What is the condition she's having? If they haven't asked about the cause, what is the condition? If they ask in the question about the condition, what is the condition? Not the cause of her condition. Very good, Dr. Anna. We know this, she's having an eating disorder problem, but the cause of her having an eating disorder is complicated grief. Because after the death of her father, she is seeing his ghost, hallucination, and the father is telling the patient that she should be thinner. So she's having complicated grief, and it's more than 6 months. Normal grief can be there, but it's not second. And patients is not altered. They are able to do their normal activities after 2 months. But in complicated grief, it's 6 months. Normal psychotic and major depressive features are there. Like sleep, hallucination and delusions, behavioral problems. All right. So this is complicated grief and a very favorite topic in psychiatry for the AMC as well. Now look at the differences here. Weight is very minor loss in normal but significant in grief. Sleep, guilt, minor but major in abnormal grief. Illusions and delusions and hallucinations. These are present in abnormal grief. Lifestyle activities are resumed majorly in the normal grief and usually after 2 months. But in abnormal grief, they lose the energy to return to their normal activities. And normal grief patient expresses. Abnormal grief patient keeps everything inside and attempts suicide because of it, because they are not sharing their emotional instability with anyone. Severe symptoms more than 2 months. Moderate symptoms persist greater than 1 year. And in normal grief, it subsides within 1 year. Same things over here. Fear and phobias, very important. Fears continue to affect the life long after the bereavement in a complicated grief person. They can have isolation, phobias, panic attacks, life restriction, relationship problem, like in our patient. She's having eating disorder because of the hallucination and delusion of the complicated grief. Okay. You can study the complicated grief from this site as well and from the RSCGP site as well. Bereavement and early detection. Oh, sorry. This is the RSCGP guideline regarding the anorexia nervosa and bulimia nervosa, which is the eating disorder. And they have given a very detailed and very well written over here. Just give it a read and you'll be more than equipped for your exam in this topic. All right. In complicated grief, we have to treat the patient like we treat a patient of depression. We have to do the cognitive behavioral therapy. We have to put the patient on the antidepressive agents like SSRI, because they are not returning to their normal working condition and quality of life is decreasing in them. So we want to improve their condition by referring them to a counselor and by referring them to a psychiatrist. All right. Our next question is from pediatric, very, very favorite topic of AMC. Let me just make enough stars. I can't emphasize enough how favorite this topic is for the AMC. A case of chicken pox was today in the school. A mother comes with worry regarding her child of 7 years as the child doesn't have previous history of chicken pox. What do you do in this contact patient? Option A, give acyclovir. Option B, wait for the rash to come. Option C, give varicella vaccination. Option D, exclude the patient from the school. Now, this patient is a contact. This is not an index case. Unless patient is immunocompromised, we don't start antivirals in them. And we never wait for the rash to come. All right? Especially in chickenpox. We don't exclude them from the school because they are not exhibiting any sign and symptoms of the disease. But what can we do to prevent, because she has come within the first 24 hours, we can prevent the infection in the patient by giving the varicella vaccination. And it can be done in any age group. Doesn't matter if the child is a child. If a person comes to you and he or she has been in contact with a positive varicella case, you can give them varicella vaccination provided there are no contraindications to the vaccination. Exclusion from the school is done for the index case. The index case will be asked by the teachers to exclude for 5 days or until the rash dries or the vesicles dry up. That is the exclusion criteria for the varicella. Now, for any disease which is in the immunization, I want you to always use this link because it has all the information you need regarding every immunized disease, like varicella, like hepatitis, like tetanus, measles, mumps, rubella, any disease you can think up for which the vaccination has been made against is in the Australian Immunization Handbook. And you can search your term over here, just write out what disease you want to study, and it will come like this. Now, varicella, what are the recommendations? Okay, what's changed? You always go through that because they usually update it. And I have clicked it, it says no updates available, meaning no, nothing has changed regarding the protocol. So we know that it is caused by varicella zoster virus, chicken pox. Vaccination is recommended for a child aged less than, from 1 year, less than 14 years of age, from adolescents of 14 years who have not received 2 vaccinations, and particularly healthcare workers, educators in the daycare, and people who are taking care of other people in the residential daycare, right? So we know that MMRV is given at 18 months in the normal immunization. All right. And if it is more than 14 years of age adult, adolescent or teenager, but they haven't received 2 vaccination, you can give them a vaccination as well. What are the recommendations? These are all the recommendations you have. Any scenario that comes into your exam has been made from these scenarios. So if you just memorize these, you will pass the exam questions regarding any question about immunization topics. So child aged 12 months to 14 years, what are the recommendations for them? More than 14 years and didn't receive 2 doses, what are the recommendations for them? It's written over here. You just open it up and recommendations come. Healthcare workers, childhood educators, people who work in the long-term facilities, immunocompromised people, household contact of the immunocompromised people. When you have to do the serology for varicella vaccine, what are the contraindication, everything written over here. What are the adverse events? It doesn't usually come in the exam, the adverse events. All right. What is the public health management? Very important. Because it's a notifiable disease, so you have to call the healthcare department after you see a case of varicella in your practicing community. All right. What you have to do in the post-exposure profile, a person of index case, they should receive varicella vaccine within the 5 days of exposure or preferably within the 3 days. All right, so this was our question. If it is a child of less than 14 years, then use MMRV vaccine. But if it is a child who has it's have the vaccination of MMRV, you can just give them MMR vaccination. Immunoglobulin is given in those exposed patients who have some immunocompromised diseases, like pregnant patients, like a patient having cancer, patient having blood cancers, all the patients who have immunocompromised diseases, they receive the immunoglobulin. So you can all study it from here, all the information in this site. So I have taken that version from the site for the post-exposure profile access one. And this is from your GM. We know that chickenpox, very common, highly contagious. They have no prodromal symptoms in the children, but they have some prodromal symptoms in the adults. There will be some fever, low grade, myalgia, headache, and then they will be rash. Now they will have centripetal distribution. Patient will have rash, which will start from the center and spread towards the periphery. And it is a vesicular rash and it has a cropping phenomena. So we exclude these patients till the rash has dried up. Treatment is usually we advise the parents to use some calamine lotion to put on the rash because irritation is there. Give some paracetamol for the fever and keep the children well hydrated. All right. and that's it. We just exclude the children till the rash dries up. Prevention, immunocompromised or high risk ones, we give immunoglobulin. The rest we give vaccination. Okay. All right. Our next question is, a man has previous stroke few years back, now presenting with gait abnormality, increased reflexes, and 24-hour complaint of left-sided weakness. What do you want to do next in this patient? MRI brain, carotid Doppler, CT scan, or ECG? Very good, Dr. Sidra, Dr. Sherris. Very good. Dr. Anna. So what are you suspecting in this patient? It says 24-hour complaint. Are you suspecting stroke or TIA? It's not clear. It can be either of them because they have not mentioned it to be more than 24. So I would take it as TIA. But in both cases, you have to do the CT scan to rule out whether it's hemorrhagic or ischemic one. And then you can start your treatment based on your findings of the CT scan. Very good. Very important topic in your elderly or elderly care and emergency care setup. Now, assessment, we know that we do the ABCD and urgent imaging is required. Usually they recommend that MRI is the gold standard one, but in emergency department, CT scan is available readily. So non-contrast CT is the first line of investigation you would like to do in this patient. After the patient is stabilized, you can do the ECG, you can do the carotid Doppler to find out the stenosis. You can check the blood levels of the cholesterol, blood sugar, ESR, electrolytes, all the baseline investigations to rule out the risk factors which can lead to stroke. And you all mainly check the blood pressure and hypercholesteremia. These are the most two important risk factors for the stroke to take place. All right. So this is from your JN. Order a CT or MRI. CT scans are unreliable after 7 days. All right. So in TIA, which is a result within the 24 hours, or in stroke, which persist for more than 24 hours, always go for a CT scan because your management will be decided on that. If a person is having hemorrhagic stroke and you start aspirin in that patient will die. So that is why we do the CT scan. If it's an ischemic one, then we start the antiplatelet therapy right away. If it's a hemorrhagic one, we go for the neurosurgic. We call the neurosurgeon to do the management either by controlling the blood pressure or by doing the surgery. All right. Our next question is, an old man was brought to the emergency department. He was trying to cut his wife's throat while preparing food. He was not cooperating with the doctor. Now, what do you want to do as a doctor next? A, involuntary admission. B, let the patient go. C, give referral to the psychiatrist. D, give antipsychotic. So as we have discussed in the previous MCQ, if a patient is having psychotic episode, or if the patient is having major depressive episode of suicide attempt or suicide, then we do the involuntary admission because this person is a harm to himself and his surrounding, not just to himself. So we need to protect the environment as well. We start with verbal de-escalation, calling the security, and if the patient is not cooperating, sedate the patient and do the involuntary admission. If you look over here, this is the New South Wales guideline regarding the mental illness management in the emergency department. Let me just move it a little bit. Okay. First step is we do the triage, which is the initial assessment. And in triage, we check about the urgency, whether the patient needs to be admitted or managed right now, or whether they can wait or not. And we do the observation of them. All right. So, and then after that, we do the SACCIT. Now for S, we use this for the management of these mental health illness. As for safety, first of all, safety of the patient, safety of the doctor is very necessary. So we call the security, we restrain the patient so that they cannot harm themselves or others. And then we do the assessment by taking um, history from the reliable source. We do the mental state examination, risk assessment, the shebang, the vital signs, physical examination, everything. Now we need to confirm our diagnosis or provisional diagnosis, call the senior, obtain a collateral history. These two are the things we need to do. Plus, as a junior doctor, we need to also rule out some organic causes which can also cause some psychotic episode. It can be delirium as well. So we need to perform the baseline investigation to rule out delirium as well. The next thing we do is we call the senior for help. All right. We call the ED senior and we call the psychiatric senior. And this decide the immediate treatment is to be decided by them. What do they want to do? If there's some biological things or psychological therapy or social therapy, and then transfer of care is to be done by us, whether we want to explain this or this or this to the family about what is going to happen to their patient. So immediate, definitive danger to self and others. So we observe the patient, do the verbal commands if there, then we do supervision, alert the staff, call the security, and provide restraint. All right, that is how it is done. All right. Elderly man, immigrant, imprisoned for 12 years, got released a month ago. He is now complaining of productive cough, night sweats with weight loss. Sputum culture is already done. What do you want to do next? So same question which we discovered previously. Usually haloperidol is used. We need to check if the patient is intoxicated or not. Dr. Sidra, if the patient is intoxicated or having alcohol or some liver disease, then we avoid such drugs which are to be metabolized by the liver. So very good, guys. There is a big guideline regarding tuberculosis, and we have already discussed that they will always mention some immigrant or some prison or detention center, and they will have the typical sign and symptoms. Now, any patient, if you suspect this patient to be having tuberculosis, this is the pathway that you follow. If you're considering TB and patient is exhibiting the symptoms, then it's an active TB. First, you do the 3 sputum samples and you send the patient for chest x-ray. If the patient is positive, then you do the drug susceptibility testing. It's such a tongue twister, sorry. So you start the patient on appropriate anti-tuberculosis therapy for 6 months or 8 months or 9 months, depending upon their comorbid conditions. But if the patient is having a close contact, which was index case of positive TB, and he's having no symptoms. For example, this patient is a close contact and this patient is the positive TB person. Now, I want to also do the preventive measures in this patient. I will call all the members of the family of the positive contact. Now, if the patient is not, if these contacts are not exhibiting any symptoms, I would try to find out if they are having latent TB or not. I will do the Montauk's test in this patient, or IGRA is the immunographic radioimmunoassay. All right, immunogamma radioimmunoassay. These two tests are done in order to find out if the patient is having latent TB or not. If either of these two tests are positive, then next thing I want to do is check the chest to find out if the patient is having active TB or not. If the patient is having chest X-ray normal, then this patient is not having any TB. But if chest X-ray is normal, then if this patient is having latent TB, and I would want to prescribe isoniazid for 9 months in this patient. But if the patient is having chest X-ray lesions, then this is an active TB with no symptoms. So do the antituberculosis drugs in this patient as well. This was taken from here, IRCGP, and it has all the information regarding TB you want to know in your exam. So go through this guideline. Look over here. Usually the TB lesions are in the apex or the upper lobe, and fibrotic lesions are there. So this is all about TB. Give it a read from here. All right. Next is that a patient is 26 years old, presented with upper respiratory tract infection with +1 proteinuria and +1 hematuria. After 2 weeks, you called her for follow-up. You find out everything is normal in the exam. What is the next thing you want to do in this patient in the follow-up? Reassure, do ultrasound of the kidney, do urine analysis, or do RFTs to find out the function of the kidneys. Very good. So guys, if patient is having hematuria or proteinuria, either because of any disease, in follow-up, you always do the urine analysis again to find out if they are having the same proteinuria or hematuria or not. If it is persistent, then you can do the next investigation depending upon what kind of disease they were having. Either they were having some nephrotic syndrome or glomerulonephritis, what kind of disease they were having. Your follow-up next investigation will depend on that. All right. So any patient with proteinuria, hematuria, even if it is incidental, you always do the urine analysis again, and you do 3 urine analysis to confirm your diagnosis. If it is again positive, you do it again. If it is again positive, you do it again. 3 times you have to take the sample for both proteinuria and hematuria. If it is negative after 2 times, do the test again and then label the person as asymptomatic, or you can reassure the person that you're not having any kind of problem with your tract. All right. Okay. So go through this one. Hematuria, you do the urine microscopy and culture, treat the underlying infection. If it is negative, then you do the CT intravenous pyelogram or ultrasound or urine cytology. Urine cytology is usually done to find out what kind of cells are there in the hematuria. If it is positive, then you refer to the specialist to find out the cause. Either it can be the stone, either it can be malignancies, or it can be benign conditions like prostatic hypertrophy or strictures. So you always start with the microscopy and culture, then you go for imaging and cytology. All right. A child of 6 years presented with 1-day history of acute earache and very high-grade fever in the emergency. You are an intern on duty. What do you want to do to help this child? Give IV antibiotics, B, analgesics or antipyretics, C, oral antibiotic, or you want to admit this patient in the hospital. Now, acute earache with high-grade fever. Can anyone tell me what is the diagnosis? Diagnosis, guys. First, manage, very good. Acute otitis media. You can't say it's serious because there is no discharge coming from the ear. It's just acute otitis media. Now, it's just a 6-year-old child. It doesn't have any of the red flags of the acute otitis media. So you don't give antibiotics. You always start within the first 48 hours with analgesics or antipyretics. Now let's talk about why we are not giving antibiotics to this patient. After 24 to 48, after 48 hours, usually earache settles with the analgesics because the kids themselves fight off the infection well. If it is not resolving after 48 hours, then you can start the antibiotics in this patient. But there are some patients in which we start the antibiotics and analgesics together and right away. Who are those? Let's look over here. If the patient is mildly unwell and there are no red flags, this is from the RCH guideline. I have taken this picture. Just write acute otitis media or painful ear and RCH in front of it in the Google bar, and you will find this in the images as well. If the patient is mildly unwell and there are no red flags, you just give analgesics and no antibiotic for the first 48 hours of the symptom. But if the patient is very unwell, toxemic looking, there is no effort, drowsy, then you start both things right away. Don't wait for it. It's a red flag. What is the red flag? Patient is less than 6 months, immunocompromised, Aboriginal or Torres Strait Islander. These are the natives of the Australia. We call these people Aboriginal or Torres Strait Islander, native people of the Australia. All right. Any person who has only a single ear or they have an implant and you're suspecting patient is having discharge, then you start the antibiotics right away with the red flags. After 48 hours, even with the analgesic symptoms are improving, then after 2 to 3 months, you call all of these patients to have a otoscopic examination or medical review of the ear to find out if they haven't developed any other symptom or complication. All right. If the amoxicillin is the drug of choice we use for 5 days, twice a day, but if it is not helping, we can add clavulanic acid to it, or we give a combination of amoxicillin clavulanate for 5 days. All right. Clear, guys? That is how you treat the acute otitis media. If it is suppurative, start the antibiotics right away. If it is less than 6 months child, if it is immunocompromised child, if a child belongs to Aboriginal or Torres Strait Islander, if you suspect that the child has only single healthy ear, or if a child is having some implant inside the ear, then start antibiotics right away. Thank you so much, guys. This was all for today. I hope you guys enjoyed our session. I hope it was informative for you and you guys are a bit of, I was able to give you a bit of introduction, how the questions come in the exam, how you approach the question in the exam, and what kind of resources you guys can use for the exam. So all the best for your exams. Thank you so much. I'll let Dr. Arshan take the lead over here. Thank you so much, guys. Dr. Arshan, let me find him and text him. Thank you, guys.
All right. So how is it, guys? So Did you guys enjoy the session today? Thank you so much, Dr. Rabia. You did really good. I hope that all of them here, they also enjoyed the session. Okay, so this is actually how the classes are going to happen. So as you can see that there is a very organized way which is already in place for you. If you can follow what we are showing you, and if you can finish it in time, most of you will be able to go for the exam by the 5 months time. Okay, so if you know that this is the end of our 2 weeks free session, and we are going to start the course as it is. So normally the classes are 3 days per week. So as you can see in here that we take classes on Sunday, Tuesday, and Thursday. So that's always, this is the schedule that happens. And I can say to you that if you follow the theory classes that we are doing, and then we are doing the theory question solvation, and you are also doing this monthly random question solvation with Dr. Rabia. If you do all of this, and in our software already, all the 4 years sample questions are already solved and it's there. So a huge collection is there. So if you can finish all of those things, there is nothing that can prevent you to pass the exam. But obviously you need to do a lot of hard work, and there is no alternative doing some hard work for the next 5 months. Now, the course admission is ongoing. If any of you still did not join the course but interested to join, please inbox us or at least send an email to us so that we can start the process. Okay, do you guys have any question? To join Dr. Thaya, send us an email at firstaidmc4536@outlook.com. Yes, the next class is on Sunday, and I know that most of you are already you are in the course, so you will get the full schedule of this month in your Facebook group. So just keep an eye on that. You should get the whole class topics and everything in your Facebook group. Yes, Dr. Taya, just send us an email that you're interested to join the MCQ course. All good. So that should be all for tonight. I hope that all of you pass your exam and then have your dream fulfilled to start work in this Australia as a doctor. Okay, have a good night. Bye. And thank you so much, Dr. Rabia, as well.